So our next topic is vaccination in diabetes, and our speaker is Professor Nirmalya Ray. He is professor at KPC Medical College, Calcutta. So and BM Birla Heart Research Center, and he is attached with Department of General Medicine, consultant physician and diabetologist. So, Dr. Roy, please start your delivery.
Thank you, sir. It's indeed a pleasure to talk to this august gathering. I express my sincere gratitude to the organizers and in particular Dr. G.P. Bhattacharya and Mridulda for having given me this wonderful opportunity. I'm really privileged seeing some of my teachers, Professor S.K. De, who had been my teacher at Medical College when I was doing my MD, Professor Shantanu Guha and Dr. Professor Dashroti Sarkar sitting in the audience. It's indeed a great pleasure. Well, at the same time, I would also express my gratitude for this distinguished audience for having stayed back and listening to my talk. Well, when I started my practice way back in 2007, I had made a strange observation. I made an observation that why is it that many of the patients are ending up in the hospital? And I found that one of the commonest reasons why patients are ending up in the hospital happens to be LRTI. And I started looking for ways to prevent it. At that time, vaccination was not that popular in this city, and people would seldom think of doing it. And I started looking for interventions which would actually make sure that patients tend to have a long and healthy life. And I've always felt no other discipline gives you an opportunity, as does diabetes, in giving a good quality primary care to patients. And I really take pride when I see these patients of mine, all in their 90s and out of hospital. So, having said this, what are the reasons why people end up in the hospital, why people end up dying young? So when I analyzed my records and also analyzed what are the reasons for dying, if you look, between 40 to 50, most people have a cardiac event, right? And if you live beyond 50 and you go to 60 or 70s, you tend to have more often LRTI, strokes. And if you're still lucky and go to 80, then what do you die of? You die of broken hip fracture. In fact, this happens to be the most important reason why my patients die nowadays well into their 80s. That is, after a fall, they just can't survive. And that is one of the reasons why my current interest is mainly in osteoporosis. And I understand if this organization allows me, I'll come back next year to talk about that. Well, we all have patients like this 30-year-old unmarried female who's diagnosed with diabetes mellitus and started on metformin 1 gram twice daily. She is obese and wants to improve on her lifestyle of late. She is very distressed. Nowadays, we are distinguishing between two terms, depression and distress. Distress is something when you suffer, but you don't fulfill the laid down criteria for depression. And with the recent diagnosis, it is a very quite common phenomenon. Whenever a young patient gets a diagnosis of diabetes, they are quite distressed, they are unhappy, they just can't reconcile with the fact that they will have to live a little different life. And the fasting is 150 and PP 220, HbA1c of 8, and she is determined to improve her lifestyle, and she does believe in the fairy tale concept of living healthy and wealthy ever after. She is a school teacher by profession and wants to get married soon. So how do we help? Needless to say, tell this audience, we all need to have a good glycemic control of this lady, and we all need to make sure that this lady enters into pregnancy quite safe with a good HbA1c. Well, beyond this, we have a lot to do, and she does dream of becoming one of these brigade of nonagerians. So when it comes to respiratory disease, indeed COPD patients suffer a lot, but then diabetic patients do not stay back. They also suffer to a great extent. Look at the Spanish flu, which is supposed to be the mother of all the flus recorded in the history. If you look at this flu, then also the people with comorbidities die. And needless to tell this audience, in 2019, when we became a part of the history and we witnessed the COVID pandemic, we found that people who had diabetes, people who had COPD, people who had ischemic heart disease are more likely to die than ordinary people. And this is the reason why it is important that we start giving them a holistic preventive care. Now, what are the important lessons that we learned during all these outbreaks? We learned that elderly and patients with multimorbidity tend to have a much higher risk of suffering and much higher risk of poor clinical outcome. Pneumococcal pneumonia. Now, if you look at this, many of these patients who who start as viral pneumonia end up with bacterial pneumonia. Pneumococcal pneumonia had been one of the commonest reasons. Preceding respiratory viral infection antedates the development of pneumococcal pneumonia. So needless for this audience to tell this audience that adult pneumococcal vaccination given in routine purpose can actually go to a great extent. Pneumococcal pneumonia have been commonly seen as a co-infection along with other respiratory viral infection, and we do have higher pneumonia-related mortality as well as prolonged hospital stay for those patients who had a secondary bacterial pneumonia after a viral episode. WHO as well as ACC, which is a cardiology body, went on to actually advise emphatically that pneumococcal vaccination is the way to go. When it comes to the common reason for death from infectious disease in India, community-acquired pneumonia happened to be the second most common cause. The significant burden of adult pneumococcal disease in India is something very well known. Data from Mumbai as well as Shimla showed that 36% of the isolates from the CAP patients are Streptococcus pneumoniae. In Indian subcontinent, if you look, has the largest share of pneumococcal disease burden in Asia. So diabetics, needless to say, have a increased risk of respiratory infections. One of the key reasons why diabetic patients have a higher mortality to respiratory infections, particularly the respiratory bacterial infections, is because they have a poor cell-mediated immunity, and also the fact that these patients have lazy leukocytes. Diabetes patients are 6 times more likely than non-diabetic patients to be hospitalized after the diagnosis of influenza during flu epidemics. So what is flu? Why did the title say flu? Whenever we say flu, it's kind of a thing that it's not something serious, it's trivial. But for a diabetic patient, flu is not at all trivial. It's a serious event. These patients tend to suffer longer duration when they get a flu, and this is precisely because they have a poor CMI, cell-mediated immunity. And many a times these patients end up getting secondary bacterial infection, and as a result of which these patients are ending up in the hospital. Nowadays, if you look at the cardiology guidelines, the cardiology heart failure guidelines, as my previous speakers were talking about, flu vaccination as well as pneumococcal vaccination, they are important parts in these guidelines. Therefore, if you look at the importance of vaccination in diabetes, 3 times more likely to die of pneumonia or flu in diabetics. Also among the diabetic patients, death rate is something around 5 to 15% during the flu epidemics. So why miss on protecting these patients against 2 of the most common vaccine preventable illness in this population? Diabetes is associated with higher risk of pneumococcal, as I have just pointed out. It's close to around 3 times across the age range from 18 years to more than 65 years that the patients can get affected. Now, when it comes to talking about vaccination, one of the greatest problem that we face is when we encounter such a chart. It is a chart which is very difficult to decipher. Most doctors, as well as myself, I am not an infectious disease specialist, neither an immunophysician to talk in details about the vaccinations and vaccine responses. But for me, even to interpret this chart is something very difficult. So one of the easy way for all category of doctors to independently interpret this chart is just select the age first. Just look at the age first. Once you have selected the age, next look for the comorbidities. And once you have got the comorbidities, then you have the line of vaccines placed. Well, easier said than done, but ordinarily speaking, it is not that difficult if you look at the guidelines from ADA-ESD and also our very own API guideline and Geriatric Society guidelines. So for all practical purpose, when you look at this chart, first look at your age category, then look at the comorbidity category, and then you get a clear idea of what kind of vaccines you need to offer. Another important issue that comes up whenever we talk of vaccine is how to space the vaccines. In most cases, you can give pneumococcal vaccination as well as flu vaccination at the same setting. However, in different arms, don't use the same arms. These are also days when cardiologists use a lot of fancy anticoagulants, and when it comes to using anticoagulants, mind you, these are not antiplatelets, anticoags that may be warfarin, maybe azithromycin, maybe all these names like apixaban, rivaroxaban, dabigatran. In such cases also, vaccination is not a problem. Should you vaccinate such patients, make sure that after administering the injection, you hold the arm firmly for 3 minutes, right? For 3 minutes, that's what the guideline says, and that prevents hematoma. If you still want to be more sure, you can apply some ice, and that's it. However, for those patients who are on warfarin or azithromycin, in such cases, make sure that when you administer the vaccine, your INR should not be above your target range. In such cases, the chances of hematoma formation increases, right? So this is the chart. Now, when it comes to taking care of a chronic disease like diabetes, it is very important that we look at the patient from the person point of view than the disease point of view. The reason why I wanted to start with the clinical vignette is because of the fact that in our endeavor to treat diabetes, we actually end up forgetting the patient. Do you all remember the patient that we talked about? She is all of 30-year-old. She is unmarried and she wants to have a family soon and she wants to live long. And therefore, the management must be as holistic as possible. So what went wrong with our practice? I have always tried to find out what went wrong with our practice. We have entered into a disease-centric management model rather than a patient-centric management model. What happened? We forgot that she is a 30-year-old woman, little scared, little stigmatized because she has been diagnosed with diabetes. And she also dreams of having a family and living a long and a healthy life. So things actually, so what is very important that whenever we deal with such patients, we use a language that is neutral, non-judgmental, and based on facts, action, physiology, and biology. The first thing that we need to do is to assure this lady that yes, you have been diagnosed with diabetes, but you will still live the life of a 30-year-old woman, but in a little pragmatic way. Use a language that is free from stigma. In our kind of marriage-driven society, a diagnosis of diabetes pre-marriage can be quite a big deal. Use language that is strength-based. That is, you can still assure this patient that you can become a mother. You can still have a baby in an absolutely normal way. Use a language that fosters collaboration between people with diabetes and healthcare professionals. It should not be a monolithic system, rather a system which helps, like even things as trivial as vaccination should be given importance. Use a language that is patient-centric. Nowadays, in diabetes parlance, we do not use the term diabetic patient. We say people with diabetes, PWD. So So these are not my words, but the words from ADA-ESD. And therefore, we believe in setting smart goals whenever we encounter such patients. Now, what are the smart goals that we need to set? We need to set that we have to do a good deal of counseling so as to overcome the distress associated with the diagnosis. We indeed need to do a good glycemic management, and at the same time, lifestyle management and associated management like vaccination. The reason why I moved away from talking in terms of more and more data, because we know the data, but we do not quite use the data in our practice. So vaccine hesitancy across the continents is quite common. Be it US, be it UK, be it India, there are a lot of people who will not be willingly take vaccines, and because it's not something which is appreciated. We Indians, we love being treated when we suffer. When you have a shortness of breath, you want antibiotics, shortness of breath, fever, cough. But when you talk about prevention of that by taking a vaccine, we are often not quite willing. So when it comes to vaccinating patients, we need to understand that we have an array of vaccines which we can offer to the patients. I'll first start with the human papillomavirus. Now, human papillomavirus vaccine exposure is little less for me, but because I see comparatively older patients than younger patients. When it comes to vaccinating against human papillomavirus, in our country, the guidelines are up to 26 years, right? And in our country, the vaccine is mostly recommended in women, not in men. However, if you look at the international guidelines, they do talk of vaccinating even men. Particularly, in women, you can vaccinate them till 40 years of age if they have not completed their vaccine. Now, if you ask me, I have recently included this vaccination because I don't treat much of younger people. In our country, DCGI is yet to come up with a clear statement of vaccinating between 26 to 40 years, but till 26 years in our country, it is allowed to vaccinate women. And in men, also till 26 years. Beyond 29 years in our country, it remains a little skeptic issue. They say men who are homosexuals can benefit a great deal from this vaccine. In our kind of practice, we just can't be judgmental, and we need to understand the sexual orientation of the patient. Now, when it comes to hepatitis B vaccine is becoming more and more important as well as HPV vaccine, because they deal with two vaccines which prevent cancers in the long run. So hepatitis B vaccine, till the 60 years of age, you give 016. And in case if you have a patient who is about to embark on dialysis, which is quite common in my kind of practice, EGFR less than 30, and in such case, you can give 0126 months, and the dose is double, one dose in each deltoid at the same sitting. For ordinarily, we give 016. In case if the patient is about to embark on a dialysis program or EGFR is less than 30, you give them 0126, one dose in each deltoid. Now, what is also important that, again, when it comes to using one of the combined preparation of hepatitis A and B, in such case also it's 016. Ordinarily, we do not have the hepatitis A vaccination in diabetes regimen. Another vaccine which is becoming very important nowadays is tetanus, diphtheria, and acellular pertussis, which is Tdap. Tdap has found place in the diabetic guidelines because they are saying that many of the patients who suffer from cough actually have Bordetella parapertussis. So Tdap vaccine once in 10 years can be the way to go for such patients. Particularly with large-scale vaccination in younger age, we do encounter an importance of Bordetella parapertussis in patients of older age. Now, as I have said, when it comes to setting goals, it is very important we remember this beautiful picture from Annals of Internal Medicine, which talks of a patient-centric goal. Be it the fixing your sugar goals, be it fixing your overall goal. Make sure that we take into account the patient's actually targets of lifestyle. So when it comes to providing immunization, it is all the more important that, well, we have all received our COVID vaccine, hepatitis B vaccine I have talked about. Then comes the issue of influenza vaccine. All diabetic patients should receive a flu vaccination, influenza vaccination, once before the onset of autumn. A very good time to vaccinate patients in our kind of hemisphere is to do it in the month from August to October, during which time the vaccine comes in the market. Remember, the vaccine we use is not the live virus vaccine, which is the intranasal vaccine. Therefore, our vaccine can be used across all population. However, make sure that they take the current vaccine. It is a very common and bad practice which is there, that patients are vaccinated with older vaccines. So when it comes to flu vaccine, the rule is you vaccinate the patient every year before the advent of winter, the best time being August to October. When it comes to pneumococcal vaccine, about which I talked in great detail. Now, when it comes to talking about the pneumococcal vaccine, we currently have two vaccines available in India. One is PCV13, which is a conjugate vaccine, and PPSV23, which is a polysaccharide vaccine. PCV13 has got greater immunogenicity. Now, what do you mean by greater immunogenicity? It has a greater ability to afford protection to you, even if you have poor immunity. However, it does not have a wide coverage, only 13 strains. While PPSV23 is a polysaccharide vaccine, somewhat little less effective than PCV13, but a wider coverage. Now, what to use? When it comes to Western guidelines, they are talking in terms of PCV15 and PCV20. Since we do not have these vaccines, we talk in terms of PCV13 and PPSV23. Now, if you have a patient who's less than 65 years of age and is diabetic, you give the patient a single shot of PPSV23. However, the patient should not have a cochlear implant, patient must not be HIV positive, patient must not be having a primary immunodeficiency, or patient should not be undergoing splenectomy, or the patient is not on any immunosuppressant. Should this be so, in such case, you give the patient a PCV13, wait for at least 8 weeks, preferably 1 year, and then vaccinate the patient with a PPSV23. Now, if you have a patient who is more than 65 years and has not received any vaccine, in such case, you can talk to the patient about giving PCV13, and after 1 year, if the patient agrees for the PCV13, which is much expensive, you give them PPSV23. In such case, if you believe in the guidelines in our country, the guidelines is quite categorical. Since we don't have PCV15 and 20, we will go straight for PPSV23, one shot. There is no point in vaccinating with PPSV23 every 5 years, because it is a recommendation by the company and not by any of the boards. Now, when it comes for vaccination against another important disease, it is the respiratory syncytial virus vaccine. Now, this vaccine is not recommended for use in adults in our country. I understand pediatricians use this. I don't have any idea whether the dose is same as that of the pediatricians, since this does not find place in our API guideline or Geriatric Society guideline or CHEST guidelines. I would say let's wait for this vaccine to get its necessary approval. Tdap I have talked about. Another important vaccine which is finding a very important use and has a very strong recommendation is using herpes zoster vaccine. Now, herpes zoster vaccine is also a wonderful vaccine with a good amount of efficacy. Now, as I said that there is a big breach between what is there in the science and what is there in the art. The herpes zoster vaccine calls for 2 dosage. However, the vaccine is prohibitively expensive and it costs something around 24,000. Now, when I talked to my mother about taking this vaccine, soon after when my mother-in-law suffered from an episode of herpes zoster, my mother said she would still prefer to have a sari worth 24,000 rather than that vaccine because my mother-in-law suffered for only 2 weeks. So this is the situation. Well, I don't have a clear answer to this. I have written it for few times, but most of the people never bothered to take the vaccine. Therefore, I insist that we as doctors, we prescribe widely the flu vaccine, the pneumococcal vaccine, and Tdap, right, which I am starting, and offer hepatitis B vaccine if it hasn't been taken as yet. And this will go a long way. And I understand HPV vaccine will also be important, but since I don't have access to such younger patients, I don't know much about it. But should I get a chance to see young patients, I'll certainly tell them about it. So thank you very much for patient hearing. This is my wonderful team with whom I work.
Thank you, Dr. Roy, for explaining such an information in such a short time. My question is that if patient is on long-term steroid therapy,
Yes, sir.
and we want to give pneumococcal vaccine or influenza vaccine, should we double the dose or what is the schedule?
Sir, in such...
Long-term steroid?
Yes, sir. So it's a very pertinent question. Firstly, let me clarify that I am no immunophysician, but I have gone through the guidelines quite in detail because when it comes to influenza vaccine, the dose is unchanged. You don't need to do anything. You just give single influenza vaccine. Now, whether you give double dose or not, it is not a part of the guideline. So since it's not a part of the guideline, we will never say, right? When it comes to giving a pneumonia vaccine, sirs, if you assume that this patient is an organ transplant, because I deal with a lot of PTDM, which is NODAT or PTDM as we call it, new onset diabetes after organ transplant, particularly renal transplant. In such cases, it is a good practice, sir, to give PCV13 first and wait for 8 weeks to 1 year and then give a PPSV23 for so far as the patients who are expected to be on immunosuppression for a good amount of time. And I understand even sir will tell us the Chess Society also does not quite recommend strongly regarding the PCV13. They are more in favor of PPSV23 as PCV15 and 20 are not available. All the International Chess Society guidelines talk highly about PCV20, but until that comes into India, I think PPSV23 is the way to go for most patients. But should a patient have immunosuppression, like steroids, sir, as you pointed out, or one of those fancy drugs like mycophenolate mofetil, azathioprine and all, in such case, it is prudent to offer PCV13 first, followed by PPSV23. For rest of the patient, PPSV23 is good enough.
In USA, double dose influenza vaccine is available.
Sir, but one in our
country, they are recommending that vaccine.
Sir, basically we have to go by the guidelines. DCGI is the body which regulates how we use our drugs. It would be, in fact, the cardiologists sitting here would also agree when it comes to SGLT2 inhibitors. We know all the international bodies recommend that we can start SGLT2 up to 20. And in our kind of guidelines, in diabetes guidelines, we are told to continue with the drug till the onset of dialysis and even during dialysis. But our DCGI is quite categorical. Beyond 30, don't give. These are tricky situations. Now these are days of we may end up getting sued. Yeah.
Questions 1 or 2, and after that I will give some important points regarding the flu vaccine. The changes made by WHO and the changes affected in India from Srinagar state. Please ask.
So fantastic presentation. Regarding human papilloma virus, as per the DCGI, human papilloma virus vaccination,
yes.
HPV vaccination.
Huh.
So as of now, our DCGI, they do not recommend it beyond
Males.
Yeah, 29. But international standard, it is approved up to 44 or 45
40 years.
So I think 39 years ago.
Yes, that's a big problem. Even if you look at the companies, they will not say 40 years. They'll talk up to 26 years maximum. So see, most of the times nothing will happen. If somebody suffers, he is say 35, and you give a male a Gardasil and he suffers some kind of episode, something goes wrong, we will be pulled up. So for me, as also a medical college teacher, I shall not venture willingly out of DCGI permissions.
I understand, but in contrary to other vaccine, this particular vaccine can actually prevent a cancer.
I know. I think even SGLT2 is a wonderful molecule. You all swear by SGLT2, Orindam swears by SGLT2 inhibitors, but little scared. I will not want to give SGLT2 inhibitor in a patient whose GFR is say 5 or 10. I'll be very scared.
Nirmalya, here.
Yes, Shujata.
Yeah. My question is very naive. It's not scientific. You have done a wonderful job. I do practice adult vaccination for a long time, over a decade, before even the COVID, after which it is highlighted now. But just tell me, we use the multinational brands. There are 1,000 other companies, local made, and it is flooding the market. I see in my practice many of the patients getting this. So what is your take on these brands? Because at the end of the day, people tell that I'm vaccinated, and vaccines are very costly.
Yes.
If you are in a tertiary care, if you are in a sophisticated insurance-based institute, you can give, because it's a talk of giving the best, motivating. Whatever we tell here, it cannot be put into practice at the grassroots level. So kindly, there should be some advocacy regarding vaccines. So what is your
Madam,
take
when
on
it
those?
comes to these vaccines, so far as pneumococcal vaccine is concerned, I am aware that PCV13 is sold only by Pfizer. And when it comes to PPSV23, there are two companies which are selling it. One is the MSD and another is an Indian brand. Now, this has the same kind of response as, for example, the biosimilars, because these are biopharmaceuticals. You know, unless there is a difference in price, madam, better not to go in. And these two brands, they don't have any difference in price. Flu vaccine, so far as I know, sir, there is only one brand, right, sir? Flu vaccine, Actito brand.
No, flu, just, I will tell. One by Zydus and one by Influvac by Abbott.
But as I understand, they are manufactured in the same factory, sir.
No, listen, there has been a lot of change. I will just sum up.
Okay, sir.
And for madam, one thing. This is the adult vaccination, much bigger, thick booklet, reduced by the Bombay API. Just this year. If possible, try to get one. And another thing, that we are expendable to the patient ultimately. Now, all vaccinations will not give 100% protection.
That's a very important.
It will just reduce the chances. And even if it happens, then it will not be severe. One of my female colleagues did a bronchoscopy, taken a swine flu vaccine 1 month back. But the patient was suffering from bronchoscopy. She had to do the bronchoscopy and she got swine flu. But the severity was less. If there is no other question, I would like to sum up something about the flu vaccine. Just let me sum up, because
I am asking about pneumo vaccine.
Yes, sir.
If any person above 65, he can go directly to pneumo 23 without taking.
Sir, there is a tricky statement in this. If a patient is getting vaccinated for the first time and that is above 65, and mind you, in our country, so far as the API guideline and Geriatric Society guideline is concerned, they have come to the threshold of 55. ঠিক আছে, ইন্টারন্যাশনালি বলা হয় 65। 65-এ if somebody is going in for the vaccination for the first time, the statement, which is little old by the API around 3 years back, it states that you offer the patient PCV13 first. PCV13, mind you, is more expensive. Once the patient has received PCV13, you vaccinate him with PPSV 23 after 1 year. And in case if the patient has to embark on a condition which will lead to a prolonged immunosuppression, say for example patient will undergo a splenectomy, in such case you offer it PCV13, তার 8 সপ্তাহ minimum 8 সপ্তাহ গ্যাপে you give the patient a PPSV 23. Otherwise, since in our country PCV 20 or PCV 15 are not available, you can directly go to PPSV 23.
I think
For
we can
all
end here.
practical purpose, sir, if we are dealing with ordinary people and people do not have much of opinion, you directly vaccinate the patient with a single dose of PPSV 23. You are
Without taking 20.
অত কথা বলার দরকারই হবে না
Without
পেশেন্টকে।
PCV 13, I think you can just manage it a little. Excuse me, sorry. You have taken too many questions. I've got to sum up and go over to the next session.
What time you take the influenza vaccine? What time of the
Just
Sir
hold
will
on, hold on.
probably
I'm just
summarize.
telling that. I'm
Sir,
just
sir.
telling that. Summarizing. See, the influenza vaccine, Bombay and Calcutta does not have a winter season.
Yes,
So the All India Association of Chest Physicians, they have got down their released a booklet and they have advised influenza vaccination before the rainy season. You see? And for the colder regions in the north, you give end September. In UK and all, they give the flu jab sometimes in September middle or in the end September. Now, after that, I would say the composition. So far, we had added the Phuket strain of the B. Yamagata lineage. But since 2020, there has been studies throughout the world, and Corona has done many bad things. One good thing, it has almost wiped out the influenza strains. During Corona, we did not have influenza. And what they have found, that B. Yamagata strain, which we use from the Phuket, is no more found anywhere in the world, sparring 1 or 2 cases. Most of the research has been done in Srinagar by Professor Parvez Kaul in collaboration with ERS. And what they recommend now is a 3 strain, trivalent strain. Trivalent strain, they are giving, just in case I do not make a mistake, then 2 A strain from Wisconsin and Massachusetts and 1 in the B. Victoria lineage. So, if you go on giving that quadrivalent strain because of the company people, please avoid them. This is my take. Anything more? I think we have taken a lot of time, and let me finish here.
Thank you,
So,
sir.
thank you very much, because you have adult immunization very short. There is a book, get hold of the book from the Bombay API.
Yes, sir. That's a very important book. Thank you.
Thank you.
Thank you so much. Thank you, Speaker. It's time to felicitate our Speaker and Chairperson. So please stay there. I would like to request Dr. Shupriya Dotto ma'am to please felicitate our Speaker and Chairperson on behalf of HDS.